a ball of wax. It's near the entrance. Again, there's a few hairs matted here. And the surface of this wax is a bit soft but dry and sticky. You can see the underneath. I'm trying to lift this off the canal wall. I thought I'd try an ear hook, I think, at this stage to see if I can. It's a bit of a gaping at the top, so I wanted to glide the hook in, and I've now rotated it. But as soon as I turned the hook and embedded the pointy part of the hook into the core of the wax, it just sliced to it like a hot knife through butter. So I've just put some olive oil spray in there just to lubricate the plug of wax, to try and help it detach it from the canal wall. And I'm just loosening it now, you can see, just at the bottom. And now to the front part, I'm just trying to bring it away from the canal wall and into the ear. So trying to detach the skin that's enveloped around the plug off the canal wall. Now in this ear, you'll see once I remove this plug, the patient's got glue ear, and it's quite a severe retraction of the eardrum, so do continue to watch because you will see that. You can see that dead skin that's enveloped around this plug of wax. Now, this patient's ear canal was quite inclined, and it's only once I removed the wax from the ear I noticed that as much. So most people's ear canals, they do go upward slightly, around 30 degrees on upward trajectory. With this patient, I would say it's a bit more, probably 40 degrees upwards. I've just loosened this plug now, and it's, once you've mobilised the plug, sometimes you have to mobilise it. It is attached to the canal wall with all the keratin around it. And now I'm trying to bring it forwards and out of the ear. The more medial part of this ball of wax is a bit harder and drier. And you can see here now, just bringing it to the entrance. You can see those cilia, those hairs, they're on the first bend. So to the left, that's the first bend. Again, I'm just giving it a little wriggle. And as I'm wriggling it, I'm bringing it outwards. You have to be careful because if you just have to judge the correct amount of force and a pressure to apply with the suction probe, because if you put too much pressure, you're just going to push it. Because this is a ball of wax, you'll just push it, you roll this further in. If you come out too quickly with the suction probe, you lose the suction grip. So you just have to judge it, and you only be able to do that with experience and obviously whilst you're doing the procedure. And you can see here, it's finally coming out of the ear. It's quite a dark ball of wax, so this wax has been there for a while. It's almost like a Malteser. It's got that appearance, and you'll see a still image. Now that's the patient's eardrum. You can see it's yellow in the middle behind the eardrum and quite dark blue around the edge. And at the top, you've got a really severe attic retraction there. The top part of the superior part of the ear canal has been eroded. So the eardrum's been sucked in. So we call that eustachian tube dysfunction. So behind the eardrum, it's the middle ear. That should be air-filled, and the air pressure behind the eardrum should be equal to the air pressure in the atmosphere. And there's a tube, the eustachian tube, which connects the middle ear to the back of the nose, and when you yawn or chew or swallow, that eustachian tube momentarily opens and it equalises the air pressure, and any fluid behind the eardrum, it can also drain away. If that tube gets blocked at the back of the nose, there's no air behind the eardrum, so the eardrum gets sucked in, fluid can't drain, and we call that glue ear, and that's what that patient's got in the right ear. So this is the patient's left ear. This plug is a bit drier, it's a lot longer, you'll be quite surprised. I think if it wasn't for the patient's glue ear in their right ear, they would have noticed their left ear being the worst ear out of the two. Because of that upwards trajectory of the ear canal, there's a big opening at the bottom, so I tried getting the hook in underneath and rotating it, but it just slides through, so I just put some oil in there just to lubricate it, just to help me get a suction grip. When you've got kind of dry wax and it's matted, sometimes it's hard to get a suction grip. And the olive oil does that, it softens the surface of the wax, so when you put the suction probe onto the wax, there's some purchase there. Otherwise, you can, with dry wax, inadvertently push it further in. So it's quite a hairy plug of wax there. So this patient's eardrum's normal, healthy looking. Again, it's got quite an upwards trajectory, and then about 0.5 centimetre away from the eardrum, the ear canal drops down again. So that narrowing deep near the eardrum is called the isthmus. And when the ear canal goes up and then suddenly down, it creates a recess. There's a little trench at the bottom there, at the bottom of the eardrum, and to the left also. So just going back to the right ear, you can see the appearance of that eardrum, and it is really, really retracted. That's the plug of wax I removed from the patient's right ear. You can just see how dark it is in colour, and it's quite spherical, so it looks like a little Malteser, and this is the plug from the left ear. It's not as dark, so it's not been there as long, and loads of hair strands there, so it's matted hair, so the patient trims their ear hairs, but they need to also block the entrance of the ear with some cotton wool.